Good morning, everyone. Welcome to episode 21 of the Not A-Fib podcast, powered by the Journal of Emergency Medical Services. My name is Mark Flaughter. Some of the concepts you'll encounter in test questions and with your patients might seem difficult, but it's my goal to teach you how to understand ideas rather than memorize information. I won't teach you mnemonics or weird ways to remember things. Rather, I want you to truly comprehend pathologies and you can walk yourself to the correct answer when you're sitting in front of a test. Test taking strategies. Never change your answer unless you realize you missed an exception. For example, which one of these is not the correct choice, or all of these except. Don't assume information not in the questions or try to rationalize yourself into choosing an answer. They will give you the information you need to make the correct choice right there in the question. When evaluating your options, you have 4 options to choose from: 1 correct answer, 1 distractor, and 2 seemingly plausible choices. It's easy to eliminate the distractor or the super wrong one right away out of the gate. There will be 2 reasonable options, but you'll need to rule them out based on information given to you. Stop and breathe, stretch, unclench your jaw, unfurrow your brow, and relax your shoulders periodically throughout the test. The more you can relax, the less you'll be in a sympathetic nervous system overdrive. You can do 3 things when you're cranking out endogenous catecholamines: fight, flight, or freeze. Now is not the time for that kind of action. You need to be in your prefrontal cortex where you make great decisions and have rational thoughts. This is a test, not a brown bear attacking you or a serial killer hunting you for sport. Act accordingly. Don't go into the exam hungry or super full. Hungry and you won't be able to focus. Carb load and you'll be zoned out and falling asleep. Have a high protein snack and a glass of water. Make sure you hit the restroom right away before entering the testing facility. If you're one that struggles with test anxiety, start by contacting your employer's EAP and get connected with a therapist that specializes in test anxiety. Most employers offer 4 or 6 free sessions with a board certified therapist per year. Use your time with these specialists to learn tactics to reduce your test anxiety so nothing holds you back. Use body language to trick yourself into feeling confident leading into your exam. What do animals do when they feel threatened? They get big. They puff out their chests or stand their back fur up to look taller. Take some deep breaths, stretch your arms out wide, and remember who you are. Take up some space, verbalize positive affirmations that you will pass the exam. It might sound silly, but you hold the power in your own success, and speaking positively to you about you is where it starts. And those are some test taking strategies from the book But Why? Going Beyond the What So You Can Understand the Why of Critical Care Transport by Gwenny Winkler. Gwenny Winkler is an EMS educator who sprouted her roots in the ER and helicopter EMS. She believes learning should be fun and lives for those aha moments when her students come alive with curiosity and hunger for growth. Frequently called intense for her fast-paced and loud persona, Gwenny's ability to slow it down to connect with patients and treat their humanity along with their pathology is her superpower. When she's not in the ED, a helicopter, or in the classroom, she enjoys destroying her opponents at pickleball and cooking exorbitant amounts of food. Her husband and 5 children are the light of her life, but those kids exhaust her to no end. Gwenny is a connoisseur of Diet Coke, can, fountain, bottle, and her blood type is Torchy's Queso. It is my pleasure to welcome Gwenny Winkler to the podcast. Gwenny, thank you for your time.
Thank you so much, Mark, for having me.
So let's start with what got you into the medical field, specifically nursing.
Yeah, I distinctly remember being a second grader and checking out the hardback book we had about I want to be a nurse when I grow up. And if you could go back to Brownstown, Illinois, and if that book is still in the library and they still have the card system where you write your name on it, Gwen Stokes is going to be on there about 11 times that year because I wanted to be a nurse. Well, we age, we change our minds as we grow up, but I was offered a full ride scholarship for pole vaulting. I was a pole vaulter in high school to a college that didn't offer nursing. And I was like, no big deal. I'll just go to medical school instead. And so I went into college with pre-med. And after a year, I was like, chemistry really sucks and I hate it a lot. So I dropped my pre-med major and I went to the soft sciences and I got my bachelor's degree in psychology. And I thought, this is cool. I love helping people. This is kind of nursing adjacent. This will be fine. But I got married during college and life moved me in a different direction and I wasn't able to go get my master's degree. And I don't know if you know this, but you can do a whole lot of nothing with a bachelor's degree in psychology. You have to get your master's or your
Hmm.
doctorate to be able to do a whole lot. But I started having kiddos and I was supporting my first husband in his career. And after he finished his master's degree, I said, you know what? I just could never get nursing out of my mind. I really regret accepting that full ride scholarship and not being able to do nursing. I want to go back. And so when I was 28, I went through an accelerated nursing program. It's pretty intense. It's 4 years of nursing packed into just 15 months. I
Oh,
actually
goodness.
went to school in your neck of the woods where you're at. I think you're St. Louis-ish,
Yeah.
right? So I
Hmm.
went to
Yes, I am.
SIUE there in Edwardsville
Okay.
on the Illinois side. Went through accelerated program, did all of my clinicals in the St. Louis hospital systems, which what a blessing. St. Louis has so many great medical resources there with
Hmm.
Big Barns and Mercy and Children's and the Cardinal Glennon. Like what a great hospital system is there. So I went through my accelerated program, immediately started in the emergency department there at Belleville Memorial at the OG, the original location there, kind of on the border between East St. Louis and Belleville.
Okay.
And worked there for about a year and then moved to Kansas City, started working at a level one trauma center there, worked there for almost 3 years and decided I want to start flying. And so I started flying at about the 3.5 year mark of my nursing career and was immediately hooked. I think there are a lot of paramedics that say, I wish I would have gone to nursing school because you can make such better money in nursing. But I'm backwards. I'm a nurse who wishes I would have gone through medic school because I love EMS. Yes, I love the ER, working in the hospital as an ER nurse, but I love pre-hospital. I love the culture of it. I love just everything about EMS. And so now I do a little bit of both. I fly PRN for a hospital-based program. It's an incredible program. I drive 3.5 hours each way to get to my base because it's such a great program and I love being part of it as well. My boss is just a rare gem, right? And I would follow
Mhm.
him right off a cliff. He's so amazing to work for. So it makes it worth the drive. And then I still work PRN in the emergency department and I love getting to do that as well. So I really enjoy medicine, and I'm so glad that even past the traditional time when people start their careers at, their first round of college, I really love medicine. I love what I get to do, and even being an educator, getting to impact others in finding who they are and stepping into their own as a critical care provider is just really fun for me.
That's great. When you talk about educating, um, what type of educating do you do? Do you just do continuing ed? Do you do actual certification or licensing courses? Talk to us a little bit about that.
Yeah, sure. So, Nurse Gwenny is my full-time gig now. And so my avenue of education is in TikTok and Instagram videos, right? These
Mhm.
90-second to maybe 3 or 4 minute reels. And so no, it's not formal education.
Okay.
Nobody's getting certified or licensed because of my videos, but as a culture, when you and I went through school, Mark, we read a textbook and we sat
Oh yeah.
docile in a chair for 3 hours at a time, reading these big, long chapters. And that's not how people learn anymore.
Right.
Our culture has shifted that if I can't get someone's attention in 3 seconds, I've lost them. I had a company that contacted me that said, would you advertise our product? And their product was it looks like a highlighter, but you highlighted it over your textbooks, and then it uses AI to spit out a summary so that students don't have to read the whole textbook. And I said, absolutely not. I will not be advertising your product. I don't care how much you're going to pay me. I'm not going to advertise it because I think the students need to actually do the learning. Nobody wants to do the learning because right now we learn life hacks or recipes or workout tips in tiny little snippets
Hmm.
online that we're swiping through on TikTok and Instagram. But we need to also appreciate that we have to go back to the reading. And so I feel like what I can do in my quick reels on Instagram, on TikTok, is I can spark someone's interest. I can help make a connection for them, and they can go, oh, Gwenny was talking like this morning. My video was about hepatotoxic mushrooms that we see. Have you ever taken care of a patient who went mushroom hunting and they saw one that didn't look like a morel, but they're like, oh, I'm sure it's probably fine. And they eat it and
Hmm.
it destroys their liver, right? And
Right.
so maybe I can create a curiosity with them to go find some more reading on the hepatotoxicity of these inedible mushrooms, and they can learn more about how to take care of hepatotoxic patients, right? Or yesterday, my video was on blade geometry. For paramedics, that's really easy for them. That's something they learn in school. For nurses, it's not. But maybe that 90-second reel can create a curiosity in them that they'll say, I want to learn more about airway management. And so they can go find a book and read the whole chapter. And then I do a lot of conference speaking. I do coaching with people one-on-one. So sometimes that's nursing students who are preparing for their NCLEX. Sometimes it's paramedics or paramedic students who have sat for the NREMT a couple of times and they've not been successful. And so they schedule coaching time with me, and I will work with them one-on-one to suit it to their learning styles. You know, we have the audio learners, we have our visual learners, our tactile learners. So it's catering the education to them that maybe in a way they didn't receive it in school that will help them to be successful. So I feel really blessed and honored that I get to meet so many people in wherever they are in their journey. And just like, you know, we're rock climbing and I'm just offering them a hand and pulling them up to the
Hmm.
next level where they're at.
That's fantastic. When you talk about your coaching and your paramedic coaching your paramedics, is it primarily students or entry level paramedics, or do you see all levels of experience with your coaching?
The entire range. I will see EMTs, I see nursing students. I've had nursing students, or excuse me, nurses with 25 years of experience, but they've been a charge nurse in the ER, you know, since I was a toddler, and now they want to become a flight nurse, and so they want help reaching that next level.
Do you just get providers, or you mentioned the charge nurse? Do you get supervisory level, like paramedics that are like administrators for agencies, nurses that are like directors? Do you see all levels, not only field providers, but administration as well?
Mostly I see frontline people
Okay.
who are in direct patient care. And most of what I see is people wanting to get to the critical care level and they're just not sure where to start out, you know? And it seems to be a bimodal distribution of experience, either very little experience or a whole lot of experience, and they're kind of set in their ways and they want to make a pivot, right? I don't see too many that are, you know, the 5 to 10 year experience mark. And it's really fun for me to work with these people because all of them, every single one of them, have a growth mentality. And I think in EMS and in healthcare altogether, we do see a lot of that complacency, and this is the way we've always done it. But the people who seek out help from me, all of them 100% have a growth mentality. They're open to feedback and they want to grow and get better. And that absolutely energizes me as someone who also has a growth mentality, that I try to learn one thing new every day, whether it's about medicine or patient care, or if it's just something in life, right? Maybe a
Mhm.
biblical concept or, you know, how to fix something. I like to learn something new every day. And so it energizes me. It fills my cup to work with like-minded people who also want to grow, who want to get better, who want to challenge the status quo in the way we've always done things.
Mhm. That is definitely here in the fire service, fire-based EMS. That is ingrained. Is this is the way we've always done it? So breaking that stigma and being progressive and trying to break the mold, if you will, or go in a different direction can be met with a lot of resistance for
Yeah, I
sure.
was really encouraged by the last 2 years of the opening ceremony for FDIC. I think this year, the maybe it was just a keynote speaker. I'm not sure if it was the opening. I just caught a clip of it on Instagram a few weeks ago. The gentleman was talking about leaders. Leaders set the tone for challenging that status quo, for being willing to grow and move beyond it. And he also referenced like PTSD doesn't just come from these horrific patient care scenarios that we see, these mangled bodies in accidents or from fires, but in the culture of the fire industry, right? And then the year before that, the opening keynote speaker talked about that this is the way we've always done it, and we've always had this focus on fire, but really we've firefighters have done such a great job of fire prevention that they've essentially worked themselves out of work. And so
Yes.
90% of our calls are medical now and only 10% are fire, but we're still putting our emphasis, our resources, our training so much on fire. And EMS is seen as the redheaded stepchild that like, ugh, nobody wants to be on the ambulance. Everybody wants to be on the fire rig. And I know I'm not part of the fire community, but in EMS, it's kind of fire adjacent. There's a lot of overlap in our culture and our mindsets that we have to embrace, right? Not just tolerate EMS, but embrace it and put some of our resources and our training there. So I was really encouraged to hear both of those keynotes from the last 2 years of FDIC and hopefully see a change in the EMS is no longer the redheaded stepchild. It's the bread and butter of what we do.
Right. And for a lot of agencies, ours included, EMS brings in revenue. They
Yeah.
help provide revenue. So to not embrace something that's bringing money into your agency seems a bit unusual to me.
Yeah, for
Yep.
sure.
A couple times you've mentioned air EMS, helicopter EMS. So
Uh-huh.
what planted the seed for you to get into helicopter EMS?
I've always had a growth mentality. I've always been hungry to go to the next level to challenge myself. I don't like to be comfortable,
Mhm.
which sounds a little bit backwards. I always want to be challenging myself to do the next big thing. So whether that's in physical fitness, I want to be able to PR my squat clean, or I want to be able to climb a 14,000 foot mountain, always reaching for the next big thing. And when I felt like I had become a really strong ER nurse, the next step was becoming a flight nurse. And I'm 8 years in and I'm still not comfortable.
Okay.
Anytime I think I'm like, okay, I've got this, I'm really comfortable, I'm good at this, I'll get a case that just challenges me. A patient
Mhm.
who's just, they've got a swan and a transvenous pacer and they've got 8 different drips and, they're intubated and really difficult for us to achieve good ventilator settings on this patient. Like, whoa, okay, I'm uncomfortable. I'm
Mhm.
uncomfortable. I still have work to do.
Mhm. When what are some of the challenges you faced when you first got into being a flight nurse, going from working in the emergency department to working on a helicopter?
Yeah, easy question. I was a really strong ER nurse. I thought that meant I was instantly going to be a strong flight nurse. And boy, the fall from that rise on the Dunning-Kruger effect, ouch. That was a hard fall. And I didn't realize that I was going to have to start at ground zero yet again, that I thought all of those skills and the knowledge and the competency I had was going to translate to a high level of skills and competency and knowledge on the flight side. And it was totally different. I remember getting on my first scene call and I had no idea what to do. I was like, what do I do with my hands? Where do I go? Right? Because it wasn't just hop in their ambulance, right? It's really easy to go from the helicopter to hopping in the ambulance and taking over care. But when the patient is still entrapped and the fire department is still working on getting that patient out, I'm like, what do I do? And so
Mhm.
I had to do so much learning. I didn't know how to read an EKG. That was something I had to rely on my partner and then have them teach me how to do it and then seek out additional education on my own. Life in the fast lane, I'm sure like if they had library cards for their website, mine would be worn out because I've gone to Life in the Fast Lane so much to learn about it because I knew nothing, right? I knew how to do an EKG and hand it to the doctor for them to sign. But pre-hospital, I don't have it to a doctor to interpret and sign and give back to me. I have to interpret that. My partner and I have to work together to do that ourselves. And so what I teach with folks who are looking to get into flight now, I will tell them, look, you're a really strong ICU nurse. You're a really great ER nurse. I need you to know that the expectation isn't that you are a really strong flight nurse right out of the gate. The expectation is that you are a willing to learn nurse. It's that you are a hungry to grow nurse and you're willing to listen to your paramedic partner who's been doing this for 12 years. You're willing to learn from your preceptor who has so much more experience at this And it's okay to not know everything. As a matter of fact, if you came into this thinking you know everything, I'm going to be really worried that you're going to be out here like a, Wild West cowboy.
Hmm. You mentioned you've been doing flight nursing for about 8 years, I think you said.
Yes.
What are some of the changes that you've seen over that time in the flight community for air EMS?
We've gotten a lot more tools just in the 8 years that I've been doing it. When I first started, we had a Revell ventilator, and it was a good ventilator, right? I think today you could still blindfold me and I could operate it without even looking because that was the one that I
Mhm.
learned on, I studied on. I became intimately familiar with the Revell monitor. But now it's pretty much standard across the board that everybody has a Hamilton T1. And I love the Hamilton T1 because it's capable of so many things. I can do high flow nasal cannula. I can safely ventilate micro preemies, really tiny babies. Thank heavens I haven't had to do that yet, right? I'm not on a neo team, so I mostly do normal sized pediatrics and adults.
Mhm.
It's capable of a lot of really cool things. POCUS is becoming more available. My program doesn't do POCUS yet, and I don't know that we ever will, but that's one of the tools that a lot of people have. Carrying blood is now the standard, and it thrills me to see that it's becoming the standard on ground transport too. I'm sure you've read the book Lights and Sirens about the original EMS crew that started with Freedom House. It took me a second to
Yes.
think of the name. With Freedom House and what they were able to do and how little resources they had. And it was essentially just a transport service, right? Transport in a little bit of medicine. And now it's on the helicopter. I have the ability to do so many things with my patients that we couldn't do just 8 years ago when I
Mhm.
started. We didn't carry blood when I started 8 years ago. I know there were programs carrying it, but mine wasn't. And it excites me to see if I put on my thinking cap and shake the 8 ball to see what are we going to be able to do in the future. It thrills me to think of what capabilities we might have down the road for EMS.
You mentioned the blood. Last month, we had Holly O'Byrne from DC Fire and EMS talking about their blood program. What what difference have you seen, maybe in your personal experience on the helicopter, or just as a whole, the blood in the field? What
Yeah.
uh, what changes or what benefits have you seen as far as carrying that blood and being able to make a difference on the patient's outcome?
Absolutely. It's an enormous difference, right? You and I were both trained where two large bore IVs and a pressure bag on a liter of fluids on each side. And
Right.
we know now how detrimental that was for our patients, that we were introducing room temperature fluids, which were cold, which we know the trauma triad of death includes hypothermia. We
Right.
worsen that by strapping them to a cold long spine board and losing that heat loss sucking into the long spine board, and we give them essentially cold fluids. Room temperature is cold for the body, right? So we've cooled them. We have decreased their clotting capacity by introducing all of these fluids, right? I remember overhearing a conversation between the ER doctor and the trauma surgeon. The trauma surgeon had come down when we paged out a trauma that was incoming, and the trauma surgeon said, "Do we know if this patient is on blood thinners?" And the ER physician says, "Unfortunately, they are. It's called normal saline that they're
Hmm.
receiving pre-hospital." Right? It acts as a blood thinner and prevents the trauma patient from being able to clot. And so it worsens two of those three things on the trauma triad of death when we give fluids. We know that if a patient is bleeding, they don't need volume replacement by way of normal saline. They need volume replacement by way of what they lost, and that's blood products. And so we've talked about for years the golden hour of trauma. That first hour is detrimental for those patients. That's the make or break time. And if I can introduce three units of blood products and give the plasma first, which the reason that we give plasma, right? I remember when we first started giving blood, I thought, oh, it makes sense to give them packed red blood cells first because that's the oxygen delivering component of the blood. That's what they need, is they need volume that can deliver oxygen, but you're wrong. We need to give plasma first because plasma contains all of our clotting factors except platelets. And so we can help them to clot by giving them plasma first and then chase it with packed red blood cells so that then they can deliver that oxygen to the tissue. And so if I can give them those components before we get to the hospital where we can give whole blood, because my service doesn't carry whole blood, praying that someday
Mhm.
soon we can carry whole blood. So kudos to you programs that are carrying whole blood. I can give them those and get them to the hospital where they can receive their definitive treatment, and whether that's the OR and we can repair the vasculature that's been damaged by the saw that went through their leg or the bullet hole that went through their, femoral artery, whatever it is, they can receive that definitive care. I'm buying them time and quality time to be able to get to their definitive care. And so, yes, I have absolutely seen it make a difference on patients who I think 8 years ago, when I wasn't carrying blood, this patient would not have made it to the hospital. But now that I can give them blood, we can get them there.
Outstanding. Hopefully, you see it more and more frequently as the successes and the studies show what a benefit it is and what a difference it can make.
Yeah,
One
absolutely.
one of the things you mentioned earlier in our discussion, and we'll kind of pivot just a little bit, is you talked about keynote speaking. I know we had corresponded earlier this month, and you were actually a keynote speaker at a conference here in Missouri. Talk to me a little bit about, for those that have kicked around the idea of becoming a speaker, what got you into it, and what are some of the things that you've learned from being a speaker and delivering keynote addresses?
Yeah, it's difficult. I don't love it. I love teaching. I love being in the classroom, but keynote speaker, like I feel like I am successful at connecting with my students. And so if someone asks me to be a keynote speaker, I just need you to know that I'm going to be out in the audience. You can't keep me on the stage. I'm going to come down and I'm going to
Mhm.
walk through the crowd and interact with them because that's how I thrive. And as a speaker, number one, you need to know your audience, right? If I were to go to a physician conference, it's going to be a little bit more formal. It's going to be heavier academic. Whereas with my paramedics, these are the people who get a lot of their education by scrolling through TikTok and Instagram, right? They're used to watching modules online who have a lot of pictures and graphics and things like that. And so the interactivity is really important for me as an instructor and as a speaker to interact with my crowd. And so knowing your crowd, preparing a presentation that's going to connect with them well at their level. We can't teach over people's heads. If you're speaking to a conference where it's mostly EMTs, right? If I'm only talking critical care, I'm going to lose them. That's not something
Mhm.
that's pertinent to them because that is not within their scope of care, and it might be a little bit over their head. So knowing your audience, having something that will captivate their attention. My personal policy is that I don't put anything more than about 20 to 30% of the information on the slide. If I put everything I'm going to say on a slide, boring. Everybody's going to be snoring through it, right? And I've worked myself out of a job because if they can read it on a slide, they don't need me as the
Right.
speaker or the instructor. So I usually just put a couple of graphics or something to illustrate the point that I'm talking about and to keep myself on track because I'm very, very prone to taking a side quest. I'm like, hey, let's talk about this thing over here for a second. Keeping myself on task really helps the learner to stay engaged with me as a speaker. And I think if someone is interested in doing a little bit of conference speaking or teaching, just start applying. There are so many conferences out there. You can start with your state conference and apply to be a speaker, or some of the smaller critical care conferences like ECHO. Um, some of those conferences, and then just start working your way up and then start applying to speak at something like AMTC or CCTMC or even FDIC.
Mhm. When you get a speaking engagement, do the organizers, do they give you the topic they want to discuss? Will they give you the audience makeup and let you determine what you discuss? How does that work when you book a speaking engagement?
Yeah, so usually people reach out to me and they say, hey, I'm from the whatever state board of EMS. We would like for you to come and keynote speak. I'll ask them a few questions. Okay, how many people are usually do you expect to be there? Do you have mostly BLS providers, mostly ALS? Do you have critical care? Are we talking about supervisors? And then we just kind of talk about what topics they're looking for. If they're looking something on leadership, or if they're looking for me to talk about how to keep your learners engaged in education, that's a common request I get. And then we just kind of work together to figure out what works best for them. So I never dictate it all on my own, and they very rarely call me and say, you have to speak on this one thing. It's usually a
Okay,
conversation between both of us to find something that I feel well equipped to speak on and that they're looking for that would connect with their crowd.
awesome. You've mentioned a couple times already, and that's primarily the reason I want to have you on is your social media presence.
Yes.
You've talked about the education that you do through your reels, which are fantastic, by the way. I've been following you
Thank
for
you.
several months now. And start us off. What got you into developing your Instagram presence? Just what was the impetus for it? What turned on in Nurse Gwenny's head one day and says, you know, I want to be on Instagram and I want to do these reels to help educate people.
Yeah, so in 2019, I started teaching critical care. I'd been flying for about a year and a half, and there was a ground service in the area where I flew that was looking to roll out a ground critical care transport program, but they didn't have anybody to educate their providers, and they asked if I would be interested in helping. And my role just kind of expanded little by little, and I eventually had a whole critical care curriculum that I was teaching on my own. And then the ground program in the community where I grew up in Southern Illinois, they were also looking for someone. And it just so happened that my grandpa had COVID and he needed to be flown to St. Louis from the small Southern Illinois community where he was. And there was a thunderstorm that day and they couldn't fly. And this ground service needed to transport him and they didn't have any ventilator training. They didn't even have a ventilator. And he was really, really sick. And so that connected me with them and I called them and I said, do you want to do critical care? Is this something you guys took my grandpa? You had to take a nurse and a respiratory therapist with you because your providers didn't know. Can I help you teach your providers? And they said, yeah, sure. And so I paired up with Rural Med and taught some of their providers how to perform critical care and rolled out the program there. And then I got hired by, at the time they were IA Med, they're now Impact EMS. And so I started teaching with them and started doing little videos. And I'm not with them anymore. But in the time that I was with them, my best friend was a flight paramedic. And she would always ask me when she had questions. I remember one of the first times she said, Gwenny, why? Why in my crush injured protocols do I have to give my patient albuterol? They're not having a hard time breathing. What's albuterol going to do? And so teaching her the why that your crush injured patient, when they are freed from that crush, they're going to have hyperkalemia. And we can cause an intracellular shift in the potassium to reduce the serum potassium with albuterol. So giving them a continuous albuterol infusion has nothing to do with bronchoconstriction and everything to do with shifting the potassium so that these patients don't go to a fatal dysrhythmia caused by that hyperkalemia. And so it kind of became a but why. And I had a note on my phone that anytime somebody, whether it was a coworker or myself, came up with a but why question, people are so much more likely to comply with a protocol or a policy or procedure if they understand the why behind it. I even use this in parenting, right? I don't just tell my kids to
Right.
do something. I have to help them understand the why. Okay, well, you can't have snacks in your room. If you leave crumbs on the floor of your bedroom, you're going to have bugs and mice in your room. And we don't want bugs and mice in the house, right? And so now they're like, oh, yeah, you're right. I definitely do not want a mouse in my room. I'm not going to take snacks in my room. You have to give someone the why, right? And I don't just want someone memorizing facts. So I started this note on my phone. Why albuterol in crush injuries? Why plasma before red blood cells? Why? And I just kept a list, and I didn't know what I was going to do with it. One of my flight partners at the time, his name is Jared Patterson. He said, "Gwenny, you need to start a podcast," or "Gwenny, you need to do this." And I'm like, "No, there's so many good podcasts out there. Like there's nothing that anybody else isn't saying that I can say." And so it wasn't that. And eventually I thought, we need a new book, right? We have the Back to Basics and the ASAT book, but those were published in 2011 and 12. Like medical literature, we like to be less than 5 years old. And so that's what caused me to write the book, But Why? It's 309
Mhm.
practice test questions to prepare people for the FPC and the CFRN, but it includes these rationales. And sometimes the rationale is an entire page long, and I've got a couple of graphics that go with it. And when I first started writing it, I wanted to sound academic like some of the other people that had written the books, the Will Wingfields, the Eric Bauer, the Orchid, the I can't remember the author of Back to Basics. Orchid Lopez, I think is his name. And when I was struggling, it was like trying to walk with cinder blocks on my feet. And then eventually I was like, no, Gwenny, this isn't why people come to you for questions because you sound like all of those other people. They come to you because you break it down into simple concepts. And so that's where the But Why book came from, is people always ask, I need to know the why. And so then once I decided to write like Gwenny instead of to write like what I think people expected, that's when the book just kind of flowed out my fingers as I was typing. It just came to me. And then when I've published the book, But Why, I thought, well, maybe this will turn into something someday. Maybe I should have my Instagram handles locked down and maybe I could do something with it. So the day that I published But Why, it was the day before I flew out to Haiti for a 2 week trip to educate providers there. And so all of my followers ordered the books and they got to see it before I did because I was out of the country. But I started doing little Instagram posts and it was little graphics that I made and it wasn't really connecting with people. And so one day I just did a little video on the trauma triad of death and boom, it became wildly popular very quickly. And I was like, oh, okay, so it seems like people want to see videos more than they want to see a graphic with a caption explaining something. And so I started doing these little videos. And my friend Jimmy Apple, he's EMS Avenger, he said, why aren't you on TikTok? And I'm like, oh, TikTok's for the young people. Like, I'm old. I'm going to be 40 in 3 weeks. I don't belong on TikTok. And he said, no. He said, I'm even older than you are. Yes, I think you should do this on TikTok. I think you would reach a lot more people who aren't on Instagram. And I thought, this is never going to go anywhere, but okay, if you insist. And so that started growing pretty quickly. And now I love it. I look forward to, I'm always on the lookout for opportunities to create content, whether it's the patients that I'm encountering myself or a clinical mistake that I made and I learned something from it. And so I want to share that learning opportunity with my followers. Or like yesterday, I looked out my back window and I noticed that there was mushrooms all over my backyard. And it reminded me of a patient I took care of once who
Mhm.
ate some of those and they were really, really sick. And so it's create a video there. Sometimes it's when my husband and I are on a bicycle ride and he asked like, what do you do if somebody's trapped in that grain bin? I'm like, perfect content. So I have an appointment coming up with KCFD to do a video with their grain entrapment rescue apparatus to be able to show people this is what we do. And so I think I get a lot of people that follow me that aren't in medicine, and they're just like, it's really cool. Like, I'm just curious
Mhm.
to learn about these things. And it allows me to connect with people and reach them where they're at instead of trying to rope them into a classroom.
It's fantastic, and I always love when Mr. Nurse Gwenny makes an appearance on your videos. It's always exciting. But one of the other things that I've noticed about your videos and your reels is the locale or the setting. That sometimes is the hook. You talked earlier about how people their attention spans. Well, you get that hook with the settings for your videos, whether it's at the helicopter, like you mentioned, on a bike ride or in some other setting. That gets the hook, and then once they're hooked, they will listen to what you say. And 9 times out of 10, probably 9.9 times out of 10, it's like, oh, wow, that is really, really interesting. So the combination of those two things is just fantastic for getting your message across.
Oh, thanks, Mark. Yeah, I do look for ways to like when people see it, go, what on earth is she doing now? Like several
Mhm.
weeks ago, I was doing a video and I had a pair of underpants on over my leggings and talking about how, giving a bleeding patient, normal saline is like, changing your underwear instead of addressing the problem of, sharting in your underpants. Excuse me for using the word shart, right? Like you're hiding it, right? You're hiding the fact that the
Right.
problem still exists, right? And so finding interesting and just comical ways to illustrate different points, or the time that I used a whole bunch of shot glasses of Diet Coke to talk about the difference between SIMV and assist control ventilator modes.
Mhm. Yeah, it's stuff like that that just it's fantastic because it's out of the ordinary. And like I said, it hooks you in and makes you want to listen to what you're explaining because it's just an unusual way to present it, which everyone likes the unusual, especially if you're in the healthcare field, especially the pre-hospital healthcare field. Um,
Yeah, we sure
so
do.
so once you started seeing response with your TikToks and your Instagram, when did that come about as a result? Was that a result of your success and your popularity on social media? Is that what spawned the website and going into the coaching?
Yeah, it was because I couldn't keep up with the demand that I was getting just through like DMs and stuff. I got to a point where I was spending a few hours a day responding to DMs because it's really important to me that like my followers had given me a gift of their attention and their time. They want to learn from me, and that's an honor, but it's also a responsibility. And as it was growing, and this is now my full-time job, this is how I support my family
Mhm.
is by through the book sales, through coaching, and through doing some webinars that I do and conference speaking. This is no longer just a side hobby. This is my full-time gig. And so Mr. Nurse Gwenny had a little bit of experience. He's not in healthcare or medicine, but he owns a landscaping company. He built his own website. He built a website for a faith-based company that he did some volunteer work for. So he built my website for me, and it's still a work in progress. We're still growing it. But eventually I'm going to have an LMS, a learning management system, where people can come, because I get at least a couple times a week, somebody will say, man, I wish I could have gotten a CEU. Like, hey, this was better than my health stream module. I wish I could get some credit for this.
Mhm.
So that's something we're working on, is putting it together where people can come to me for their CEUs, that if they learn, like, look, not everybody likes the way I do things, and that's okay. We have to have multiple different teaching styles because there are so many different learning styles. But if people are resonating with the way that I teach, I want them to be able to come to me and get the hours that they have to have anyway. Why not make it fun and exciting and something that they're going to comprehend? So it's a work in progress. We're getting there.
Outstanding. It's you had a video I think recently of you. I think you and your family helping you with your new book,
Yeah.
the the ER book. Why don't you talk to us a little bit about that new book that you just published? I think, what was it, when the last month that got
Yeah,
published?
it just came out the first week of May. It's called the ER
Mhm.
Nurses Clinical Field Guide. And I wrote this for me. I wrote this for the brand new ER nurse me that didn't know what I didn't know. And so it was actually, we had to take out a second mortgage on our home to be able to publish it because they were so expensive to publish, because I had it printed on vinyl material. It's not a book like my first one where you can sit down
Right.
at the table and read it. This one is for when you are in clinical practice and you've got a patient right in front of you. And I actually have a pre-hospital one in the works that I've been working on. This one took me 7 months. I'm hoping the pre-hospital version is out by Christmas. But it's vinyl pages and it's spiral bound and it has tabs on the edge so that you can say, okay, my patient is having an ABG drawn. I don't remember how to interpret an ABG. So you grab the ABG tab, you flip it open to the ABG page, and it has a methodical approach, right? I don't teach the taco method or the Rome method or anything like that. I just teach a straightforward, methodical approach that will never lead you astray of how to interpret an ABG. And then I have a little blurb on all the different types of derangements, your metabolic acidosis, your respiratory, what could be causing it. And then, more importantly, what to do. So, this book isn't a study book like my first one. This is a clinical practice book. Let's say you've got a patient with an arterial line and you're like, oh crap, I haven't zeroed an A line in 6 months. I can't remember how to do it. And so, this page took me 2 weeks to write. It took me forever to draw all of these art line waveforms and the instructions on how to zero the line, on how to look for over dampened or under dampened, and then what that could mean, what's causing it, and how to fix it. Let's say you get a patient with something stuck in their exutory auditory canal. You can go to the EENT page and you read about, okay, how to take care of this. So what's your normal intraocular pressure? What can cause an elevated IOC? Things like that. So those things that you don't see every day, you can just flip open to that page. There's even drip charts in the back. A reminder, always follow your local protocols, but
Mhm.
here are the common doses. Here are why we use that medication. Here's what you need to be looking for. And then it's on the vinyl pages so that you can just wipe it down when you're done, because of course, you're going to get sputum and spit and blood and who knows what else all over this book. But it's just to help you while you are in practice, take care of the patient in front of you.
That's awesome. That is great. Um, so what you talked about, your learning management system, talked
Yes.
about the pre-hospital book. What else is on the horizon for Nurse Gwenny?
So I'm currently working on accreditation. I've applied for accreditation. It's a really long process. So the earliest I'll hear back on being accredited so that I can start offering CNEs or continuing nursing education will be in September. And in the meantime, we're building the LMS so that as soon as we get accreditation, we can launch it and people can start attending courses. As paramedics, you've got to have 60 hours every 2 years to renew your national registry. Nurses, it varies based on your state. Here in Missouri, you don't have to have continuing education to renew your license, but the hospital I work for, we have to have 8 hours of cardiac, 8 hours of neuro, 8 hours of trauma every year because we are all three of those accredited, the hospital is. So I'm going to create a library of content where it's going to have videos and interactive ways of learning to be able to keep people learning. And even if you don't need CEUs, it's going to be as low cost as we can get because I want to get it in the hands of as many people as
Mhm.
possible. so that, my goal isn't just to make money and support my family. Yes, of course, I have to do that because these 5 kids got to eat something, right? But I want to improve our industry. I want for people to have a hunger to grow, to be better for their patients. And that so that I can have an impact on patients I never knew existed by impacting all of these providers. And as well, it's a service to myself. It holds me to a high accountability that, like, who am I to be teaching others if I'm not learning myself? And so I love it when people pop in the comments on my videos and they'll say, if I do something on shoulder dystocia, I might have a labor and delivery nurse jump in the comments, and I always ask them, hey, teach me something. You're the specialist, so you teach me. And then that helps me to continue growing and learning as well.
As is want to happen with anyone on social media, you mentioned just somebody pop it in the comments. Do you ever get negative interaction? And I'm sure you get some sort of negative interaction. And if you do, how do you deal with that? Because it's so many people on social media. You have your keyboard warriors who hide behind their anonymity. So how do you deal with the negative interaction with the haters, if you will?
Yeah, I get very little of that, and I'm very grateful for
Good.
how little I get. And a wise friend of mine, Alex Jobber behind Emergency Resilience, she said, if you live by their praise, you're going to die by their sword, right? When people say like, oh my gosh, your videos help me so much, like, yes, that's encouraging, but I can't let that cause me to be complacent. I can't put all my stock in the positive feedback I get, because then that negative feedback that I get is going to wreck me. And so anytime I receive any kind of criticism or negative feedback, whether it's on the social media channels or, from my medical director at work when he does a case review, I always have to stop and look, is there any truth in this? Even if my kids give me feedback, I try to routinely ask my kids, how can I be a better mom? And if they say, stop making me clean my room, I think, is there any truth to that? Is there any truth that says it's okay for them to not clean their room? Sorry, not sorry. You still got to clean your room, right? And so sometimes there is truth in that feedback, though. In like, hey, Gwenny, whatever the feedback is, like, hey, your information is incorrect on this thing. That's old data. I have to go, is there any truth to that? Okay, hit the internet and so look for an NIH article on whatever the topic is. Has the data changed on that? And if I was wrong, then issuing a correction. I've done that before where I had a video about non-invasive ventilation and about what the ETS on the Hamilton means. I had one part of it backwards. And my friend Melody RT, she's another social media creator. She is a Canadian RT and she's a brilliant clinician. She contacted me and she said, hey, I didn't want to put it in the comments, but that thing you said about ETS, that one little thing you got backwards. So the next day I issued a video. I left the original video up and I said, hey, yesterday I talked about ETS and I got this thing wrong. And I'm so glad that Melody helped me. So I had to look for the truth in that negative feedback. And then if there is truth in it, grow from it, learn from it, right? But if there isn't truth in it, then I just have to let that go. And that has to be okay. I have to be okay with other people being wrong about me. I had someone who I get the most common negative feedback, and I probably get it once or twice a month, is that I talk too fast. They're right. I do talk fast. My brain goes fast. But that's why I connect with some people, because
Mhm.
they want the rapid fire, but it's not for everybody, and that's okay. I had somebody say I have too many lines on my forehead. It's true. I do have lines on my forehead because I speak fluent eyebrow, right?
Mhm.
And so
Mhm.
that's okay with me. I don't do Botox, and that's just they're gonna have to be okay with me having lines on my forehead. I'm okay with it, and if they don't like it, that's okay. They don't have to follow me. I had someone say you should consider makeup. And it just laughs. And I'm like, that's okay. Like, I'm smart and I'm funny, so I don't have to be pretty. So
There you
I'm
go.
okay not having makeup. So, yes, I do get a little bit of negative feedback. And I thank people when they offer helpful feedback for me, and not to get too wrapped up around the axle and hurt over it. If it's negative feedback, that's a service. They've done me a favor. And if there's no truth to it, then just let it go.
Awesome. That's great. As we get ready to wrap up, we're coming up on an hour here in a little bit. Is there anything that you wanted to talk about or touch upon that we haven't discussed so far?
Yeah, there's something that if anybody ever gives me an open mic to speak about whatever I want to speak about it, here's what I'm going to talk about. I am not passionate about nursing or education. And people they always like, what? That's like a record scratch moment for them. They're like, no, you do seem so passionate about nursing and education. I love being a nurse. I love getting to educate others and helping them become stronger nurses or paramedics or what have you. But I am passionate about my husband and my children. I am passionate about being the best wife and mom that I can be, and friend and sister. That's what I'm passionate about. And I think so many times in EMS, this was me. When I first started flying, it became my identity. Everything had to do with how I could be a better flight nurse or the fact that I was a flight nurse, right? And so we put the stickers on our car, and our Facebook profile picture is us in front of the helicopter. And none of those things are inherently bad, right? It's good to be proud of the work that you're doing. But if we let that become our top priority, that can be taken from us at any moment, right? We can be hurt, whether on the job or off the job, and that's going to take away the use of our hands. If I can't use my hands, I can't be a nurse. I can't place a chest tube or put an IV in or intubate a patient. That can be taken from me so quickly. And if I have sunk my entire identity in who I am as a flight nurse, then when that's taken from me, then sorry if you just heard my son hawk a giant loogie from the other room. That was disgusting. I hope the microphone filtered that out.
I
If
didn't
that's
hear it, so we're good.
good. If that's taken from me, then I crumble as a human being. And I know that we see it a lot in the fire service, where we have a man who became a firefighter at the age of 19. He put in 30 years at the fire service, and then he retires and he doesn't know what to do with himself. And unfortunately, we see some really sad situations that happen from these gentlemen, and I don't want that for anybody, whether it's a firefighter or a paramedic or a nurse, right? Whether it's they retired and now they don't know what to do with themselves, or it's taken from them. Either they lose their license through a catastrophic mistake that they make, or an injury, a back injury. How many of us have a back injury in this industry, right? It can be taken from us at any moment. So make sure our priorities are right, and that our legacy is not just how good of a nurse, paramedic, EMT, firefighter we were, but in what an incredible human being we were through our relationships outside of work. It's okay to want to do good work on the job, but make sure that's not the only part of us, and that we are spending time caring for our own humanity and not just obsessing with who we are as an employee.
I could not agree with you more. Just to emphasize your point, when I was still on the floor here at the fire district, we had one of our engineers had a heart issue. Ultimately, had surgery and was told he could no longer do the job. And he struggled for several months afterward trying to find a direction because his identity was wrapped up in the fire service. And when that was taken from him, like you just described, he had a very difficult time finding a new direction. Ultimately, was able to do that, but it took him a while. So I can tell our listeners that what you say is exactly true. When their whole identity is their job or being a nurse, being a paramedic, and that no longer is possible through either retirement, injury, or some other means, it can be difficult. So there, you have to have something outside of work about which you need to be passionate. And I could not agree with you more on that.
Yeah, yeah. I'm glad to hear that. And I think it's becoming en vogue in our industry to be caring for ourselves, to be able to,
Mhm.
manage our own mental health, and caring for who we are as human beings and not just as clinicians. And it thrills me to see that culture shift.
Yeah, absolutely. A few episodes ago, I had a battalion chief from one of our local districts talk about peer support and how important peer support is, and we've had many guests talk about the importance of mental health and taking care of yourself, so that when you do finish the job, that you have something else that you
Yeah.
can focus when you're done.
Yeah.
As we wrap up, and I don't know if you have time, but I always ask my guests for my own selfish reasons to help build my library. What's the last book that you read?
Um, The Road Back to You. It's all about the Enneagram. Are you familiar with the Enneagram?
Yes.
Okay, so what's your type? Do you know what your type is? I'm a type
Not
two.
uh, I might be type 4. I'm not 100% sure.
Okay. Yeah. So I recommend that everybody go online and take a free Enneagram test. Don't pay for it. There are places that'll charge you $20, but there are free ones that you can take.
Right.
And it goes back to caring for who you are as a human being. And it helps you with, if you've got that growth mentality and you want to be better, you have to know yourself better. And there's a paragraph in that book that talks about having a lack of self-awareness is like walking through a minefield with clown shoes on. You never know when the toe of that shoe is going to slap down on a mine that explodes in your face. And understanding ourselves allows us to also understand other people. And so I'm an Enneagram 2, I'm an empath. And so I can use that as a power, or that can be a blessing or a curse. And so an empath that allows me to connect with people and to feel emotions with them. But if I don't take good care of that strength that I have, it can become a weakness. If I'm in an unhealthy state, it can be a weakness. And say, I work at pediatric cardiac arrest, and that those parents are just distraught and they're crumbling. And we've all heard the screams of a parent who's lost their child. And if I carry that too much, if I empathize too much and take on their emotions, and I have secondhand grief, that can wreck me. And that's where we
Mhm.
start to build a library of grief that creates a PTSD complex. And so having the self-awareness to know that I'm an empathic person. And so, yes, I can use it for good here. And over there, I have to say, no, thank you. Those emotions are not for me. Then I can protect myself. And so the road back to you is all about the Enneagrams and the strengths of each types and the weaknesses. And the first way to mitigate a weakness is to be aware of it. And so it's a really good book that talks about how to know yourself and to use your strengths for good and not for evil.
That is great because I can't remember where it was, but I just read an article on secondhand grief earlier this month. So I'm glad that you brought that up and we're able to connect those two things together. So as we wrap up, we've talked a lot about your social media presence. So what handles do you want to leave for our listeners, for those that need to find you?
Yeah, on TikTok, I'm nurse.gwenny. And on Instagram, I always have to pull it up and look at it because I can never remember which one's which. On Instagram, I am Nurse Gwenny RN. I actually just launched Facebook recently because I got enough requests for people who aren't on Instagram or TikTok, or they prefer Facebook. So just search for Nurse Gwenny on Facebook. I also have a YouTube where I put all of my videos. That tends to be my international followers. They have easier access to YouTube than they do some of
Okay.
the other apps. And so my videos are on there. And then my website is nursegwenny.com. It's Gwenny. About once a week, somebody calls me Gweeny instead of Gwenny. It's two N's, not two E's. So nursegwenny.com. That's also where you can find all of my books. I have 3 books. I also have some really funny stickers on there, like an electrode placement sticker. It's just a chest with like a cloud and grass and smoke and fire, right? Because that's all how we all learned it.
Yeah.
So just a few fun things like that. And you can book some coaching time if you want to spend some one-on-one time, if you've been having a hard time passing some of your exams. I'm happy to help study with people or just whatever they need. If they want me to come speak at a conference, I've got a spot on my website where people can ask about that. So thank you so much, Mark, for having me. It was such an honor to be on the podcast. I'm excited to listen to some of your other episodes.
No, thank you for joining me. I appreciate your time, and I was tremendously and very pleasantly surprised when you got back to me so quickly. So thank you so much.
You're very
Um,
welcome.
for us here at the podcast, our Instagram handle is at not underscore a underscore fib underscore podcast. And our email address is not dot a dot fib dot com dot podcast at gmail.com. Gwenny, thank you once again for your time. For everyone else out there, thank you for listening. Take care, and we'll talk again next month.